Hello. Okay, great. Hi, everyone. It's You're all distinguished Californians here, and sit here, and supervisors, Congressman McClintock, who gave such an inspiring speech last night. It's a momentous occasion. I've been a doctor since 1970. I'm a very old timer. I never dreamed I'd be here at this time speaking under such uh, historic occasion. It's probably the most important speech I can imagine ever giving. Quite frankly, I was a virologist in my early days. I had training at the NIH. I overlapped with Fauci, and I might have a few things to say about him during the course of this, but try to be kind, not throw darts at where they might be appropriately thrown. But I have a background in virology. I was a professor at Harvard after I graduated from medical school in 1970, and I went on to UCLA School of Medicine. And I thought I'd live my life like my colleague Joe Latipos here, who's emulates what you can do in academia as a physician in a great way. But I thought that's where I would be. And then about 30 years ago, I just said, I really need to go into clinical medicine. And so I tried to find a place in California where I might be able to make a difference. And I chose the Imperial Valley. And it's been a incredible setting to be associated with, or region to be associated with extremely wonderful people. It's an economically deprived area, one of the most lowest standards of economics in the state. But people are very appreciative of what you do. I set up the HIV program there when I went there, and I've stayed with that. And so I've been able to do many things that I couldn't have done if I stayed at Rodeo Drive or Beverly Hills in practice. And so I've done primary medical care. I've been a hospitalist, and so I treat patients that are hospitalized. I've seen in the battles of HIV that early treatment is so critical, and I took that approach when I started there, and I got criticized, actually, and even, however, that's the standard of care now. You treat early. You knock that virus out. You prevent that virus from damaging the immune system. And that's the case in all areas of medicine. You treat early. You avoid the complications. You let the patient recover and have a healthy future continued existence. And that's puts me in an unusual position in that I've been on the front lines of COVID-19 since the pandemic began. I've worked in an urgent care clinic because of my colleague, a very exceptional physician named Brian Tyson, set up in the Imperial Valley what should have been the fever clinics of the United States. And he and I had been working together as hospitalists in the Pioneers Hospital for years and years. So we had great confidence in each other. And I have a clinic in Brawley where I do outpatient medical care. And I combined my clinic work with COVID in Brawley with my work with my colleague Brian Tyson in El Central. And what that allowed us to do is something very unusual. The other aspect of me is that I also take calls in the hospital for days, consecutive days on weekends. Usually I'm too busy during the week, but I go in on the weekend to do the hospital call. And so I've seen the whole progression of COVID-19 from the the bad flu, and I'm going to show that in a slide to show the science, because there is good science, and I appreciated Assemblyman Gallagher's comments about science and about evolution of science. I appreciated also a comment he made about public health officials trying to set policies that have marked and really impaired what should have been done from the very beginning. But in any case, so there's a circle of empathy, and the people like me and others are in that circle of empathy. People that are treating COVID-19 and COVID-19 patients themselves, and Joe Ladapo and Brian Tyson and all the others. And then there are others that are outside of this circle of empathy, and they're throwing stones, or they're saying, establishing policies, and they don't really have feel the impact until what we're seeing now, that we're all feeling it, this what's called a tsunami of COVID-19 that should never have happened. But I've been given a little more time, so I hope you don't mind my being a bit rambling. I try not to be when I make presentations, but I feel so strongly about this that I want to get my message out and describe what brought me here, that brought me in communication with Jeff Hewitt, and how that happened. It's rather interesting, actually. But it's a great honor to be here, and it's as I said, it means a tremendous amount to me in my career. I've been in medicine for 50 years, and I'm not going to leave it. But this is the most important communication I think I will ever make or have made. And I just want to keep going a little bit to give you the background of what this has been and what we've done and what should have been done from my perspective. When we were faced with COVID-19 coming around in February, March, I was working in my clinic, and I would go down to the urgent care clinic to take shifts there, 8-hour, 9-hour shifts, and I researched what would be good to treat these patients. I knew in HIV you need to treat early, and other illnesses, treat early. And I researched back to SARS-CoV-1, or the 2005 spread, and what was being done, and there were results with chloroquine, hydroxychloroquine, that were really quite remarkable in vitro and in vivo. And independently, I looked at what Dr. Raoult was doing in France with hydroxychloroquine, zinc, and azithromycin, and then our hero in the United States, Vladimir Zelenko in New York, when it hit there earlier than it did on the West Coast, he had a protocol for risk-stratified treatment with hydroxychloroquine, zinc, and azithromycin. And zinc is a critical inhibitor of the virus if it gets in the cell. And hydroxychloroquine carries it into the cell. And hydroxychloroquine has a number of other antiviral actions. And I, as a scientist in my early days, that appeals to me, to know that there are different mechanisms of action. It's not just one aspect of this agent. But in any case, so I came to Brian, my colleague at the urgent care clinic, and I just saw he was using the exact same protocol. And the purpose of what he had wanted to do and has done for this 10 months is to bring patients in an orderly way and screen them and give them confidence in their what they're having to face, and to determine how bad the condition is, and then really treat them quickly. And that's what we did. And we did that from March until today, and we continue on, and we've improved what we're doing, because there are other agents that can be added to the treatment algorithm. I'd like the first slide, if I could, to come up, because I'm going to just keep talking, but this is the culmination of all of this work. It's a paper that is in a peer-reviewed journal, Cardiovascular Research Reviews, or Cardiovascular Medicine Reviews, I should say. And it's titled A Multifaceted, Highly Targeted Sequential Multi-Drug Treatment of Early Ambulatory High-Risk SARS-CoV Infection, COVID-19. So I'm honored to be one of 57 authors on this paper. Joe Latipo, who will be here speaking later from UCLA, is one of the co-authors, and Brian Tyson is a co-author. It's a paper that is authored by Peter McCullough, a cardiologist internist from Baylor, who's an incredible human being and clinician, and who saw from the very beginning that, as we did independently, that you need to attack the early phase of COVID-19 effectively. And I'm going to come to the pillars of pandemia that he, in a slide that he loaned to me for this presentation. Actually, it's up now. Good. Thank you. Anyway, I'm going to explain this to you very quickly, but I want to get back to what brought me here and where we are now. So just as a quick summary of my work with growing all my patients in, 400 or 500, with Brian Tyson's 3,500, 4,000 treated patients. Collectively, we've screened over 30,000, doing the best job we could do. It's just 2 practitioners with a lot of great staff supporting us. And we've identified 5,000 to 6,000 positives. And this is just part of what's happened in the Imperial Valley, and we were the COVID epicenter for California in June and July. And we've had 4,000 plus patients, 2 or 3 fatalities with C-19 pneumonia, but only a very few that required others being hospitalized for short times, and all the others fully recovered. And so there was no reason to change what we were doing. This was working well. It's well tolerated. It's scientifically justified, and it should never have been stigmatized, and it should never have been put into a situation where, like we have somewhere in the United States a stockpile of hydroxychloroquine that could treat 4 million people, but it's locked up. And I just got a text today from a patient that I'm treating patients from around the country, but around in our Imperial Valley, lamenting that his temps are running high and he can't get hydroxychloroquine anywhere in the Imperial Valley. I think that's not the case, but that's what he had to lament about, and I reassured him, and I told him to take the Ivermectin and go in and get those monoclonal antibodies. And that's, as I'll show you in our multifaceted drug treatment regimen, monoclonal antibodies that President Trump received, the Regeneron and Eli Lilly regimen, are staged into the therapy. Let's see where. Okay. Anyway, the pillars. No, let me just keep going. Am I running too slow, or you're okay? Okay. What brought me here? I wanted to say in that. So we're going on treating, slaving away, doing really as much as we can possibly do, and getting good results. So we were very pleased with that. And about May, I came across a paper that our colleague, with Dr. Latipo's colleague, Dr. Harvey Reish and Miel, published, pleading for rolling out an early treatment that could be very helpful and that looked very good from studies. And I think Joe will talk about some of those studies this afternoon. But I was in the urgent care clinic when I read the article, and I was writing prescriptions and screening patients, and it hit home because it was actually what we were doing. We were rolling it out, and this was after the big shutdown took place, or stigmatization took place of hydroxychloroquine by false, really reprehensible research work that was published and had to be retracted. And embarrassingly, to me, it came from somewhat significant amount from a cardiologist at Harvard Medical School that sort of sloughed it off as just an oversight, that he didn't realize what was that he'd made these mistakes, and tarnished the consideration of this very good medication for the Western world, as a matter of fact. But in any case, I want to go forward a little bit and then bring you up to how I got here, and that is that we were seeing patients who would go to the ERs, and the ER would send them home if they didn't require intubation or admission because of severe respiratory symptoms. And they would send them home, and they still do, without any early treatment. They would send them home on things that really weren't appropriate, or weren't effective, I should say, and just let them ride it out and fight it off on their own. And they followed. That was what we were told to do. And so, getting back to the pillars of pandemia, I don't know if that slide can be shown. Okay, so this is a great illustration of what is involved in a pandemic, and Dr. Peter McCullough created this, and he's loaned me the slide. The first major pillar is contagion control, stop the spread, and that's being done. We're doing here, and it's been the hallmark of what the CDC has promulgated or recommended. The second is what has been missing and should have been there from the get-go, and should have been put tremendous effort into. And it still needs that, even though we have that, and that's early home treatment. That's what's called the pillar to prevent hospitalization. So the late stage pillar is hospitalization and dealing with consequences of deterioration, progression of this viral infection. And that's what we're being overwhelmed with at this time. It's a tsunami, as my colleague Dr. McCullough called it at the Senate hearing that I participated in November on early treatment. And it could have been avoided. And then the final pillar is vaccination and herd immunity. And we're getting a lot of herd immunity because the virus is spreading so rapidly, so it's natural immunity. And vaccination is rolling out and certainly beneficial. But we will have to continue to employ early treatment, effective methods to prevent hospitalization in the months ahead. And then now this, in a way, is, I guess, getting back to, I wanted to say how I got here. I got a call from a person in the community about a man named Cleo Hanks, Jim Hanks, who's a supervisor in our county, and then in a director of the Imperial Irrigation District, and a person whose wife I had cared for in other capacities in the years before, and we were acquainted. He wasn't my patient, but he had gone to the hospital because and this is in June, with fever and cough, shortness of breath, and all the expected symptoms of COVID-19. Very high-risk individual in his 70s, overweight, diabetic, and I don't think he minds my giving this breach of HIPAA, but he's a backer of what we're doing. And Jim was told by the ER, you don't need to come in the hospital even though you have a slightly collapsed lung. We want to send you down to the National Guard set up in the Imperial Valley College, where they provided some beds for monitoring patients, not really treatment. And then we'll bring you in when you need to come in. And so Jim's reaction was, I've seen too many people die without their family member with them during this pandemic, and I'm just going to go home. And so about that time, they called me And I immediately called him and got him on our protocol and got him in a consolidation of the protocol where we bring in not only the hydroxychloroquine at that time was the backbone of the protocol, but also the doxycycline, zinc, vitamin D, but in addition, steroids that could be employed and oxygen supplementation and inhaled steroids like it's called budesonide. And actually, let's go to the next slide if we could. Anyway, this is the science, and there is science, and this is a breakdown of the time course of the COVID-19 infection, where in the period of viral proliferation, which is in the first 7 days, there are major flu symptoms, and that's Jim was moving off out of that from the viral proliferation phase and into the cytokine injury phase or cytokine storm. And in any case, I employed this treatment for Jim at our Cleo, we call him Cleo, at his home with his daughter there helping him. And he progressively improved. Every day he got better and better, and his oxygen saturations rose steadily. And after 10 days, he was completely recovered. And that's what I've seen. Each in all cases that I've treated, there are very few that get this treatment later after 10 to 14 to 15 days, and then it's difficult for this combination to be effective. The ivermectin, now we're using ivermectin as another repurposed agent that has been used for decades and worldwide for pinworms, but it also has an anti-COVID-19 action, and it's different than hydroxychloroquine, and it's much like I got experienced with treating HIV. You use combinations of agents together. You don't just rely on one agent. And so the ivermectin can be brought in later in the time course for the COVID-19 infection and be even beneficial in the hospital in helping the patient improve their respiratory status because of its effects in the lungs and an antithrombosis effect that it has, blocking the trigger that triggers thrombosis by COVID-19. In any case, so that's Cleo Hanks, and Cleo is a good friend of Jeff and others that are here, and a really inspirational individual who's recommended that Jeff contact me, and I appreciate your doing that, Jeff. And then I've been lucky to meet everyone here, particularly Sue Frost, and it's a great gathering. I'm sorry it's so cold for everyone, but I think then I want to just go on to describe a few other things for you that I'm providing an attribution for the paper that has been published that is so important. And what's in that paper was actually directly published by Peter McCullough in July. And it's what we've been promulgating. I've written letters over the period of time with my colleagues to our California Health Department, to our congressmen. I've written to President Trump with my colleagues. I've written a national plan. I've written a very extensive critique of probably many 120 questions to have Dr. Fauci answer with regard to why hydroxychloroquine and other agents like this aren't being used, and that we've not got any responses from any of those letters. And it was a privilege for me to speak in November in Washington to the Senate with Harvey Reich and Peter McCullough there also. and it was convincing information that we provided. There was a minority witness who was just there to say, that's not enough evidence, give me more evidence. And what they do is they debate over the efficacy of drugs like hydroxychloroquine, saying that their trials, and they give trials that produce null findings that suffer from serious flaws, including unblinded protocols, absence of placebo controls, changing endpoints, truncated sample sizes. And I think by this afternoon, I hope Joe will present reviews, ongoing reviews and meta-analyses of over 200 studies of hydroxychloroquine and 44 studies of ivermectin that suggest early use of these drugs in combination with others results in substantial reductions in disease severity, hospitalizations, and mortality. But that's the important thing to realize, that we can open up, we can reopen, we can end the lockdowns, because we do have an effective treatment for the vulnerable, the high-risk individuals, and in general for others who have severe symptoms of COVID-19, if it's employed early and it's so important that doctors join in a wide way on this, that it's not just isolated physicians like myself and Dr. Brian Tyson and others that around the country, Dr. Zelenko in particular. That's not enough. It needs to be a broad-based approach. If you look at around the world, let's see. Is there another slide? There may be. Okay, this is the algorithm that was promulgated, or that's in the paper that we have in December of this year. And doctors like to see algorithms, and this is a peer-reviewed algorithm, and it's a guide that explains exactly what you do depending on what the conditions are, what the situation is, and when you employ them. And it's not just focusing on one agent alone. It's a multifaceted approach, sequential approach, where use nutraceuticals, you use monoclonal antibodies, you use the anti-infectives like hydroxychloroquine, ivermectin, or if you're outside of the United States, favipiravir, which is another anti-COVID agent, or use them in combinations. And that is what I prefer, is combinations, actually. And and then you progress to the use as outpatients of agents that block thrombosis, of blood clotting. That is a complication that's very serious in COVID-19 when it starts to take place. So if we were all on the right track in this country, this type of algorithm would be followed by practitioners widely. And what we were told to do was don't do anything. Don't use hydroxychloroquine. Don't use ivermectin. Let people go home, fight it off. And those few or smaller, certain ones that deteriorate, they'll come back to the hospital. And so the hospital doctors and ER doctors, that's what they were led to accept. And they would then employ these other agents and other means to treat the complications of COVID-19. And so from my perspective, it's important that everyone be on the same channel in this area, where you're offering an approach that's proven out. And so in our experience, we've proven it out, and we're continuing to do that. But the sad thing is we may run out of some of these medications if the numbers of cases grow too great, which is a real possibility. The NIH or when this hydroxychloroquine was stigmatized in May, and it was emergency use authorization rescinded, doctors and pharmacists became fearful of prescribing it, making it available, and the national stockpile that is 4 million or more full treatment doses of hydroxychloroquine was locked up, and it still is locked up. So if we get into a shortage of an agent that is proving to be very effective, it's important that that lockdown of the hydroxychloroquine, or the stockpile, be opened up, I should say. I think it's pretty much what I wanted to communicate today. I'm looking at my notes. Just a minute, if you don't mind. I just want to go, could we go to the next slide? Okay, I wanted to just say a few things about what's done around the world and what isn't done in the United States. And there are, you can't read this, I suspect, but these are different countries that are employing early treatment or are offering home kits that you just get off the shelf, that are the regimens with ivermectin or hydroxychloroquine and the antibiotic doxycycline and zinc, and individuals just pick them up and treat themselves, and they're getting very good results with that. And we offer nothing of that nature in the United States. So that's important to realize, that in countries that couldn't afford the high cost of medical care that we provide here in the in the Western world, they've been left to do with what they have, and they've used agents like hydroxychloroquine, particularly India and Brazil. Other countries, even like Greece, have made that a policy for early treatment, and it's yielded good results. It's rather shameful that the United States toll of deaths from COVID-19 is at around 700 per million. Countries that have rolled out hydroxychloroquine or other early treatments, ivermectin, are in the 30s and 20s per million, or 200 perhaps at the most. But so we have fatalities that should never have happened, in my opinion. So basically, just to sum up, I'd like to say that the science, and actually there's one more slide, I think. I'm sorry. Yeah, I just wanted to point out there have been some peer-reviewed articles that are out now, and Dr. Fauci said that HCQ shouldn't be used because it might have side effects, and we don't have a randomized controlled trial. Well, you can't do a randomized controlled trial in a pandemic, and I certainly wouldn't do that when I see patients recovering rather so dramatically and being so appreciative of how they've responded and how they feel. But you can do observational studies very well, and this is one that's recently published by Dr. Proctor. It's a very excellent one, was published months ago by Dr. Zelenko, of high-risk patients, risk stratified approach. And these studies all show dramatic reduction in hospitalization for the treated patients, dramatic reduction in deaths with the treated patients. And so they're there, and they need to be recognized. And we will publish our results from the Imperial Valley in this category, in this way. I wanted also to say that in addition to all the other things I do, I'm a director of a nursing home, medical director. And in June, we had an outbreak at that nursing home. And I put every one of the patients on our cocktail very quickly. 29 recovered fully of 31 that were infected. And I got backlash from our health department about doing something that that wasn't established and that might have resulted in complications and maybe take me before the medical board. So that's a matter of the circle of empathy again. The people outside the circle of empathy are not making the right calls, in my opinion. Yes. Yeah.
That I think is
Sure.
on a lot of people's mind, and you know, you are obviously someone that's very knowledgeable. You're someone, you've been in the trenches. You're someone that we should listen to, you know, very intently. However, with hydroxychloroquine, we've got these huge stores. Can you tell us what that drug has been used for decades and decades?
Well, yeah, yes, it's an extraordinary medication. It was originally made use of for malaria treatment and prevention, and it still is, and it's very effective and very safe for 65 years. And there have been millions and hundreds of millions of people treated with it, so there's a lot of experience with that medication. But in addition, it evolved into being a very effective immunomodulator agent for treatment of rheumatoid arthritis and systemic lupus erythematosus. And it's a kind of agent that should have received attention for its antiviral action. It's a it's a generic medication. There's no profit in it. It's dirt cheap. Our treatment costs $60, perhaps at the most. It's a broad spectrum antiviral, actually, so that if a patient actually has all these bad flu symptoms and we treat him with our cocktail, he'll get better even if he doesn't have COVID-19, if he has influenza, or if he has other coronaviruses or RNA viruses. So it's a wonder drug. I mean, it has wonderful features. I feel very really enlightened to have been able to appreciate that. I never did, and I was never trained or taught that. I was never taught that antibiotics like doxycycline and azithromycin had antiviral action. In addition, they do. And there's been a gap in what has been focused on and educated on, and it's time that change. So it's a very good question. I appreciate that, Jeff.
There you go. Doc, what are the known side effects of not only hydroxychloroquine, but this other cocktail of any of the drugs you use, other than getting better? What are the side effects of that?
Well, there are side effects. They're not major ones. Most people don't notice any effect except they feel better. The one that was stigmatized hydroxychloroquine was its effect on heart rhythm, on a QT interval prolongation. That's a very rare side effect, and that there was fear mongering where their doctors, and some doctors still tell their patients, don't take this because you might have a heart failure, heart attack. And so the side effects generally are mild symptoms, mild nausea or diarrhea, but most often none at all. And I've taken it myself for the whole pandemic, 400 milligrams once a week, and I feel fine, feel better when I take it, actually.
Well, Dr. Faria,